So where we had left off was distinguishing between between pituitary and adrenal. We talked a little bit about why, even if we're not going to change things. And really there are these three tests that we have: the high-dose DEX, measuring ACTH, and doing some kind of imaging. So the first thing I want to tell you is don't do the high-dose DEX anymore. We don't like that test in the lab. The reason being, if they didn't suppress on the low, they're probably not going to suppress on the high. It's the least accurate of all three of those tests. And so in trying to save the people money and do get what you can get out of any of these tests, I would just don't do it anymore. We're trying to get it off of the lab form, but it's going to be a struggle. So just don't order it, and then we'll quit offering it. That's how I have to deal with the marketing people. So we're not even going to talk about it. So there's a slide, and there it is. It's gone, completely gone. Now you don't have to worry about that test anymore. What we want you to do is most likely is measure ACTH. So whether you're using Antec, IDEX, or what other lab you're using, usually they'll be able to supply you with the tube. So you do have to collect it in special tubes that the lab will supply you with. These are EDTA tubes that have aprotein. And aprotein is a protease inhibitor that prevents the ACTH from being degraded. And so what you do is you just draw the blood sample into a syringe, put it into the EDTA tube with the aprotein, spin it, take the plasma off with a plastic pipette, which we give you, and put it into a plastic tube, which we give you, and then you submit that to the lab just like you would a regular blood sample. It doesn't have to be frozen. You don't have to put it on dry ice, do any of the weird stuff that we used to have to do. And there's several papers now showing that measuring endogenous ACTH is about 95 to 99% accurate in distinguishing pituitary from adrenal. Now, the question that we get very frequently in the lab is a commonly asked question that sort of makes sense, but that is, we give you a number, and then we give you a reference range. And so the reference range for ACTH is going to be 40 to 100. Okay, normal dogs have 40 to 100 picograms per ml of ACTH in their blood. Where sometimes people get confused is they've submitted an ACTH to the lab, and then we give you a number, let's say, of 75. So you've diagnosed the dog with hyperadrenocorticism. You submitted an ACTH to the lab. We give you a number that says it's 75 picograms per ml. How many people would vote that that dog has pituitary-dependent Cushing's? How many? 1? 2? Do I see 3? Come on. How many people vote it has adrenal-dependent Cushing's? How many people vote, I don't know? Oh, come on. And most of you aren't voting. And if you weren't here in the first hour, this is not acceptable. All right, but that's a common dilemma. People are like you, they call the lab. They're going, yeah, I don't understand what the hell this means. If you had a normal dog with a normal pituitary and his cortisol levels were high, his normal pituitary would do what? Turn it off. So you've already diagnosed this dog as having too much cortisol. You've already diagnosed Cushing's. Now you measure ACTH, and we tell you his ACTH level is smack dab in the reference range. It has to be pituitary-dependent disease, okay? Because any amount of ACTH floating around in that dog's blood is too much. So he has an inappropriate amount of ACTH relative to the amount of cortisol. And the other way to view it is the same way that we view calcium and parathyroid hormone. If you have a calcium of 15 and we give you a PTH value that's well within the normal range, that's inappropriate. That's primary hyperparathyroidism. A dog with an adrenal tumor will have an ACTH that's 0. All right? Won't be able to measure it. It'll come back less than whatever. So a normal or a high ACTH in the face of elevated cortisol is diagnostic for PDH, and a suppressed ACTH is diagnostic for an adrenal tumor. Very simple. And then if you had a really proactive owner who wants to do everything in one day so they don't have to come back, what we'll do is a low-dose DEX, but immediately before the low-dose DEX, we'll take blood for an ACTH. The downside of that is they may get an ACTH and they don't need it, because if the low-dose DEX comes back normal, we don't know what to do with that ACTH number. But if they never want to come back, or they don't want to come back the next day for additional testing, you can do it all in one day by doing the endogenous first and then doing the low-dose. Now let's talk a little bit about imaging, and then we'll come back and talk about this. How many people frequently will do abdominal ultrasound to look at the adrenals, trying to distinguish pituitary from adrenal-dependent disease? Okay, lots of folks. There's some caveats to this, to adrenal ultrasonography. One is you have to be pretty good at it. The adrenals are not that big. You're looking at something that's 5 millimeters in thickness, maybe 1 centimeter to 1.5 centimeters in length. So in a really big dog, that's a small thing in a really big abdomen. You have to be able to religiously be able to find the right adrenal, because the right adrenal is the hardest one to find, because the right adrenal is by the stomach and by the colon, and if there's any gas floating around in there, gas is going to obscure your vision of the right adrenal gland. So you need to be pretty good at adrenal ultrasound. The bigger problem comes in, though, with like we said in the first hour, about the problem where you can have endocrine tests and anatomy data that don't jive. And so this is the scenario that we'll describe. Let's say for fun, and this will be a depressing part of the afternoon, we took let's just say there's 100 of you in here because the math is very simple. If we trundled you all off to the local hospital and I put all 100 of you into the MRI to look at your pituitary, how many of the 100 would have a pituitary tumor? 12. Oh yeah, Bummerville. So 12% of the adult population is running around with a pituitary mass. Now, the good news is non-secretory, not a tumor per se. It's probably not going to get bigger. It's not secreting any hormone. It's just sitting there. And it's called a pituitary incidentaloma. I didn't name it. That's just what it's called. The incidentally discovered pituitary mass. 12% of the adult population. The reason I tell you guys this, because you're smart people. You get into a car wreck, fall down, do something weird, have a headache. Somebody tosses your head in a magnet. A first-year medicine resident strolls in and says, hey, you got a pituitary tumor. We're booking you into an OR. You're going to go, time out. I believe I have a pituitary incidentaloma, and I would like to talk to the head of endocrinology in this establishment, because you are stupid. And there's a whole cascade. There's a whole pathway. There's books written about this on what to do with a person who you found a pituitary mass by accident. Let's say that we took all of you, 100 of you, and took you over and put you into the CT. How many of you would have an adrenal mass out of the 100? 8. So 8% of the adult human population has an adrenal incidentaloma. Same issue. Now they're going to go, okay, does that really have anything to do with the picture here? Do you have a family history of adrenal-dependent disease? Do you have a family history of multiple endocrine neoplasia? I mean, there's a whole bunch of things they're going to sort out. What's the size? They may do some baseline endocrine tests. But chances are it's just sitting there and it's not going to do anything. We don't know the incidence of pituitary and adrenal incidentally discovered masses in dogs and cats, which is why when we use anatomy, we have to be very careful. And the most common things that happens with adrenal ultrasound is this scenario. You diagnose a dog with hyperadrenocorticism, can't tell if it's pituitary or adrenal. You bring him in, you ultrasound him. You ultrasound the right adrenal, you find a 4-centimeter mass associated with the right adrenal gland. That's big. That's unfortunate. You go over to the left side and you find a perfectly normal adrenal. Perfect normal size, shape, echogenicity. It's a hallmark poster card of what a normal adrenal should look like. You put down the ultrasound probe and you say, what? Yeah, really, that's a bummer. You go, I don't know. That was disturbing. If that adrenal mass that's 4 centimeters in size was producing cortisol, what would you expect to see on the other side? No adrenal gland. So the first thing that tells you is that thing, that 4-centimeter mass in that right adrenal, that's not the thing that's causing the Cushing's. Probably the dog has pituitary-dependent Cushing's. And what you found was an adrenal incidentaloma. And that happens in 10% of dogs with PDH. So 10% of dogs with PDH, if you ultrasound them, you're going to find something that you weren't expecting with one of the adrenal glands. Now, chances are that's a non-functional adrenal adenoma, or it's a pheo. And pheochromocytoma is, at least in one study of autopsy dogs, is not an uncommon histologic diagnosis. A lot of dogs die from other things, go to necropsy, somebody takes out their adrenals and finds that they have a unilateral pheo. They're not showing signs of hyperexcitability, tachycardia, hypertension. They're not bleeding out into their abdomen. They just have this pheo sitting there. So you have to be very careful when you're looking at the imaging data. And like I said, whenever the imaging data doesn't support your hormone data, you always go back to the hormone data. And in that scenario I told you about with the right adrenal mass and a normal left adrenal, an ACTH level will sort that out. Because if his ACTH is normal or high, that's for sure PDH. But then you have to decide and talk to the owner what you're going to do about that 4-centimeter adrenal mass, because that's not the reason why he's there today. So there you go. 12% of you have a pituitary tumor. Well done. All right. Let's talk a little bit about atypical. So we talked very briefly in the beginning about meal-induced or food-induced Cushing's. These are 4- or 5-year-old dogs, classic signs of Cushing's. Atypical cushinoid dogs are the same age as your regular cushinoid dogs. They're older dogs. All the classic signs of Cushing's. PUPD, polyphagic panting, thin skin, all of that stuff. High alk phos. You run a stim test, they're normal. You run a low-dose dex, it's normal. And what these dogs have is that they have a problem with sex steroid overproduction. So the adrenal cortex makes not only cortisol, but it makes all of the sex steroids. So from cholesterol down to cortisol, everything else is possible. And if you do one of those adrenal profiles through the University of Tennessee, typically these dogs have suppressed post-ACTH cortisols. They're actually a little bit low. And very high sex steroid concentrations. And particularly, they tend to have elevated progesterone and 17-hydroxyprogesterone. And the reason that that's happening is that progesterone and 17-hydroxyprogesterone and cortisol all bind to the same glucocorticoid receptor in the body. So the dog, whether it's cortisol, progesterone, or 17-hydroxyprogesterone, will look cushinoid, will look hyperadrenal. All the symptoms are going to look identical. And if you have that pattern where normal low dose, normal stim, high sex steroids, then you still have to work them up and find out, is this pituitary or adrenal in origin? Because they could have a unilateral adrenal secreting tumor that's producing progesterone or 17-hydroxy, or they've got bilateral adrenal hyperplasia and they're producing too much 17-hydroxyprogesterone and progesterone. And we'll show later on when we look at Trilostane, but these are dogs that probably have a primary adrenal enzyme defect in how they make cortisol. So since they can't make as much cortisol as they would like, all the precursors to cortisol build up in the blood, and it's those precursor steroids that are causing the symptoms of Cushing's. These dogs respond really nice to medical treatment. They respond well to Trilostane. They respond well to Lysodrine. The other scenario that you see in practice is the dog, like Pomeranians, who is the classic, who come in with a bilaterally symmetrical endocrine alopecia, but no other signs. They're not PUPD, they're not panting, they're not polyphagic, they don't have big livers or thin skin or high alk phos. They're just bald and in an endocrine pattern. And you run thyroid tests on them and they're normal. You test them for Cushing's and they're normal. You do an adrenal steroid panel and they have very high sex steroid levels in their blood. And those dogs probably have what's known as a 21-hydroxylase deficiency. They lack the enzyme necessary to lead to the final step in the synthesis of cortisol. So they're running around with slightly lower cortisol levels than normal. Again, because it's blocked, all of the sex steroids build up in their blood, and you can measure that through the lab. And those dogs also respond. There's There's 3 papers showing a very good response in Pomeranians and dogs with what's called alopecia X to Trilostane therapy. Because as I'm going to show you, Trilostane works very high up in the adrenal cortex. So those dogs respond really well. Now, the thing with those dogs that I always tell owners is that your dog will respond equally well to a sweater. You know, if all your dog has is a bilaterally symmetrical endocrine alopecia and no other symptom, all we're treating is a cosmetic thing here. We're growing hair. And I can grow hair in your dog by putting them on these medications, but then these medications have to be monitored. So you're going to have to do blood tests, check electrolytes. You're going to be spending a lot of money and potentially inducing a side effect because as far as we know, those dogs don't develop any other abnormalities as they get older. Versus the other dogs with classic clinical Cushing's, those are dogs that we want to treat. We want to treat them because we want to get rid of the Cushing's. So how do we decide what to use medically? Well, these are all drugs that people, and we have data on to use in dogs. Lysodrine, selegiline or deprenyl, Trilostane. We don't really use ketoconazole, bromocriptine, or metirapone in dogs anymore, either because efficacy is low or side effects are pretty high. So we're just going to focus on the first 3. This is another reason to keep owners off of the internet. Okay, so let me just ask a question. How many people right now, if they had a pituitary-dependent dog, would go to Lysodrine as their first-line drug? How many people? Okay. How many people go to Trilostane first-line drug? How many people say, I should have gone to the oncology lecture? This is really very annoying. Okay, so what an owner will do is that if you say, hey, we diagnosed your dog with Cushing's, these are your treatment options, they're going to go home and, of course, they're going to illegally get onto the internet. And they're going to Google Lysodrine, and they are going to lose their frickin' mind because they're going to learn lots of really good things about Lysodrine. A, it was developed as a chemical warfare agent. Fascinating. That sounds like a good plan. It's a derivative of DDT, the pesticide that kills baby bald eagles. Excellent. When it gets into the soil, it stays there for 4 million years. Really good. All strong selling points. Yet you want to give it to their little dog once a day for a week and then every week for the rest of its life, where it will stay in their fat until it dies. So a lot of people are not really good with Lysodrine. It ended up not being a very good chemical warfare agent, but what it did do is that when you gave it orally to dogs, it causes selective necrosis of the adrenal cortex. So basically what you do is you give enough Lysodrine to shrink the adrenals, to get enough necrosis so that cortisol production is suppressed, but not so much that you're affecting aldosterone. Okay, so when you're using Lysodrine the way that we use it, you go through induction phase where you give it for a week. That's to get a lot of the drug into the adrenal cortex because it's very fat soluble. And then they go on to maintenance to keep fat and blood levels of Lysodrine sort of at steady state. And the way that you monitor it then is you do stim tests to measure cortisol, and you check electrolytes to make sure you're not getting into an issue. Yeah.
I had an associate from Australia. She said they would give Lysodrine intentionally to kill the adrenal gland and then treat
Addison's. Right. We're going to talk about that and tell you why that's an insane idea. Let's just talk about it now. No, I don't want to talk about it now. We're going to talk about it in a couple of... We're going to talk about it now. See, you can see the slide there. You're cheating. You knew this was coming. All right, so how well does Lysodrine work? Well, the good news is the drug works pretty well. We've been using it in dogs since 1960. So lots of experience with Lysodrine in dogs. And if you look at the published papers, there's no prospective paper. It's not approved for use in the dog. It'll never be approved for use in the dog. I only know that because the FDA, because I've spent a lot of time in this part of the country with my friends in Rockville. Lovely city. The FDA, strange people working over there. But they will never approve it for use in the dogs because it's an environmental issue, and so they don't want to see the drug anymore. So if you look at efficacy in dogs, 80% of dogs have a good to excellent response to treatment with Lysodrine. So that's pretty good. 25 to 40% experience side effects, usually mild, usually GI, usually go away when you stop the drug. And then you just start with the lower dose and eventually titrate your way up. 5% develop full-blown Addison's. Mineralocorticoid, glucocorticoid insufficient. It can happen during induction, during the first week. It can happen during maintenance. It's sort of unpredictable. However, it begged the question that she asked, which is, well, why don't we just strive for that? And so they actually did a paper in the Netherlands where they took a bunch of dogs with PDH and they said, look, we experienced this percent of side effects, and more annoyingly, 58% of our dogs relapse when they're on maintenance OPDDD. And the reason that they relapse is that you're basically torturing the adrenal. You're giving them enough Lysodrine to lower cortisol, which causes their ACTHs to go crazy high, drives any remaining surviving adrenal cell to become hyperplastic. And so eventually it loses its efficacy, and you got to reinduce them. So the people at Utrecht said, okay, let's just do this. Let's make them all Addisonian. So what they did is they gave them 100 milligrams per kilogram of Lysodrine every day for 30 days in a row. See, these people bought shit. That's big bags of stuff. Some happy vendors down there. 100 mg per kg every day, 30 days in a row. On day 3, they started pred. On day 5, they put them on a mineralocorticoid replacement. And then they followed them out to see what would happen. Could they impact this 58% relapse rate? That was sort of the goal of the paper. 1-year relapse rate was 12%. Yeah, much lower. 2-year relapse rate was 47%. It's really hard to kill every adrenal cell. So they grow back because you're not getting rid of the Cushing's. The tumor's still there, still secreting ACTH, and eventually, should the dog live long enough, the Cushing signs come back. The other downside of that is that you're substituting Addison's, which we'll talk about later, for Cushing's. And Addison's, if you don't treat it right, they get sick. Cushing's, if they don't give the medication, it's annoying. Addison's, you don't give the medication, they're dead. They're dead. So I don't like that protocol from the standpoint you're substituting a potentially fatal illness for one that's more annoying. And the other thing is, in the Netherlands, it's way cheaper to treat because Florinef is dirt cheap and DOCP is way less expensive. So when they did a cost analysis, it's way cheaper to make him Addisonian than it is to keep treating him for Cushing's. So we don't really use that protocol, although it is available. We've used that protocol in dogs where we're using Lysodrine as chemo, where we're trying to treat in a metastatic adrenal tumor. So we're using it as a chemotherapy agent, but not so much to treat regular Cushing. Now, 80% effective in the hands of internists who use the drug all the time. How effective is it in the hands of general practitioners? Well, they did a study looking at differences between dosing patterns amongst internists, dermatologists, and general practitioners. Is there a dermatologist here? Excellent. We have 2 dermatologists. They have unique personality characteristics. They don't like to work very much, and they don't really like sick animals. That's why they went into derm. So when they have a hairless dog, their goal is to grow hair. And you can grow hair on a hairless dog with much lower doses of Lysodrine than I would use. It just takes them longer. And so the way that they dose was way different. When we looked at the dosing patterns of general practitioners, the efficacy rate dropped from 80 to 57% in controlling clinical signs. But when you looked at the average dose, their dosages were way lower. And the reason they were way lower, when we asked them, well, why aren't you using the recommended dose? And they said, well, I'm really afraid of side effects. I don't like side effects. And so what they were doing was substituting decreased side effects for decreased efficacy, but as long as they felt that the dog and the owner were happy with the degree of control, then they were comfortable with that. So there's a lot of leeway. Again, when we're using Lysodrine or Trilostane, there's no magic number. The number is you're trying to get rid of the symptoms because, again, with either one of these drugs, we're not treating the disease. We're just blocking, mitigating the effects of cortisol. Like I said, that drug will never be approved by the FDA, and that drug's going to go away. So if you're using Lysodrine now, you're probably going to have to come up with another plan. Right now, it has orphan drug status at FDA, which means as soon as another company can show that they have another drug with equal efficacy, then the company that makes Lysodrine can stop making it. And right now, its only approved use in humans is a treatment of adrenal cortical carcinoma, and there's less than 200 people in the U.S. taking the drug at any one time. So they want to get out. They want to stop making the drug. So they probably will. Because we've got platinum-based and Gemzar-based chemo protocols with equal efficacy to Lysodrine, so I suspect that it will vanish soon. Now, a drug that is approved by the FDA to treat Cushing's in dogs, pituitary-dependent, not adrenal. This drug, selegiline, does not work for adrenal-dependent disease, is Anapril. So I will tell you, so that I don't go to jail, that I was the original patent owner for selegiline, started a pharmaceutical company, did the clinical trials for the FDA, and sold it to Pfizer. So we don't have anything to do with the drug anymore, but we did know a lot about the drug. We started looking at this drug after we went to the lecture by Dr. Langston on frozen addicts, basically looking at dopamine. And what this drug does is it blocks the metabolism of dopamine in the brain, so you're raising endogenous dopamine levels in the CNS, which then serve to suppress ACTH and hopefully then lower cortisol. So non-adrenal-lytic, non-adrenal enzyme blocking, so you don't have to do blood tests. There's no reason to do ACTH stims, check electrolytes in dogs who are taking the medication. They get dosed 1 mg per kg in the morning. We give it with food because it increases absorption. We give it in the morning because we know that in people with Parkinson's disease, if they take the drug at night, it inverts their sleep-wake cycle. We don't know about dogs because we never did that in dogs. And because you don't have to monitor blood tests, the only thing you have to monitor is improvement in clinical signs. So we usually dose them for 30 days. If they're not responding in 30 days, we double the dose to 2 mg per kg, treat them for another 30 days. If it's not working, it's not going to work. Those dogs probably have no dopaminergic neurons left in their brain, Therefore, using an enzyme to block the enzyme that degrades it isn't going to be helpful. If it is working, we just leave them on that dose until they die of something else or until they no longer respond to it, and then we switch them to Trilostane or Lysodrine. Yep.
Cost factors. Do you have any recommendations? I mean, in a large dog, this gets like $10 a day.
So the cost, your life sucks. Big dogs are, I mean, the people with big dogs, they're always upset about how much everything costs. It's just, now, you can use generic. You can get compounded selegiline, and right now, apparently, the 5 milligram tablets are like back ordered forever, or the bigger tablets are back ordered. You can do compounded. We've used a fair amount of compounded selegiline, and that might make it a little bit cheaper for them. It would probably still be cheaper than using Trilostane or Lysodrine if they're really that big. But they save money because they don't have to do stim tests and electrolyte tests. And that's one of the things with Cushing's that we didn't talk about, is that owners need to understand up front it's expensive. If you're using Trilostane or Lysodrine, you're going to be doing 5 or 6 stim tests in a year, electrolytes, office visits, plus the cost of the drug. So, it's not an insignificant amount of money. How efficacious is it? When we did the studies for our friends in Rockville, Maryland, efficacy was 50 to 70%. Less, for sure, than Lysodrine, less than Trilostane, and only 20 to 30% response in dogs with really severe symptoms. And the dogs with really bad symptoms probably don't respond to the drug for 2 reasons. A, it's been going on long enough, they don't have dopaminergic neurons left, and B, the owners don't want to wait 1 to 2 months, and neither does the vet, nor would I recommend that you wait 2 months. It's not a drug to use for rapid control. If you want rapid control of Cushing's, you're going to use Trilostane or Lysodrine. If you have time and the symptoms are mild and you have an owner who doesn't have that much money for monitoring, then I think it's certainly a reasonable thing to try. Because it is an MAO inhibitor, you should not be given concurrent MAO inhibitors to dogs who are taking selegiline, which would mean Midaban, Amitraz, selective serotonin reuptake inhibitors, tricyclic antidepressants shouldn't be used concurrently because those drugs will raise serotonin levels in the brain. That's what they're supposed to do. MAO inhibitors will raise serotonin levels in the brain as well. And what can happen is something called the serotonergic syndrome, which results in death. Now, death, the FDA never likes. It's very bad. We don't know if that happens in dogs because we haven't done it. But I would certainly encourage you not to use those drugs concurrently. Trilostane, though, yes? We have them come in at the end of the first month and the second month, and if they're doing well, then we have them come in every 3 to 4 months after that. Unless they call and say, hey, my dog's PUPD now, or he's starting to lose hair. Then we'll have them come in sooner. Now, Trilostane is the drug that we use most in our experience. In the last 600 dogs that we've treated for Cushing's, all of them have gone on to Trilostane first. That's sort of what we've been doing. And then only using Lysodrine in dogs that fail. And the dogs so far that have failed have been less than 20 dogs that we've not been able to control with Trilostane. It used to be in the U.S., then it went away from the United States, became available in Europe where it was approved for use in the dog. Now it's approved for use in the dog in the U.S. Works in dogs and cats, works on pituitary and adrenal, has a very high safety profile. And so because of that, this is a drug that we like to use. It's different than ketoconazole, which was the adrenal enzyme blocker we used to use before. It just works higher up in the cascade, and it's much more potent in its ability to block cortisol, but it also has the ability to block aldosterone. And so whenever you're using Trilostane, you have to view it and monitor it just like you do Lysodrine. What you're looking at, though, is equal, if not slightly better efficacy and fewer side effects when you compare Trilostane to Lysodrine. And we'll show some data on survival. How many people have the adrenal steroid cascade on the wall at home? Seriously? I think the roof is a better place because then you can look at it on the ceiling and marvel at the majesty that is the adrenal gland. So basically your adrenal takes cholesterol out of the blood and does 3 things. It shunts it down to aldosterone to make electrolytes. It shunts it off to cortisol to make glucocorticoids, or it can shunt things over to sex steroids for magical, mystical reasons that we're not exactly sure. The ovary, the testicle, and the adrenal all look the same from a biochemical standpoint. They all have the same enzymes. It's just that the receptors that are responding to whatever secretagogue it is are different. So in the adrenal cortex, this is all ACTH mediated. Now, if you look at the top of this cascade, you see 3-beta hydroxysteroid dehydrogenase at the top of the cascade for all 3 pathways. That's where Trilostane works. It blocks everything from scoop to nuts. So if you have dogs with elevated progesterone or 17-hydroxyprogesterone, it'll work. If you have dogs with elevated cortisol levels, it'll work. So that's the reason why dogs with atypical Cushing's responds, why dogs with that alopecia X, which we think is a 21-hydroxylase, you can see CYP21A2, that's 21-hydroxylase. If that enzyme is not present, then the sex steroids build up in their blood. And you can get rid of those sex steroids by blocking the enzyme one step up so that they can't produce those enzymes. So it's a very, very potent inhibitor of all adrenal steroids. Yep.
This is a stupid question. Could it cause a high elevation of cholesterol?
No, it will not. No, it's not a stupid question. Because you are looking at cholesterols at the top of the cascade. Right. What you'll notice, though, is that you don't see an enzyme name between cholesterol and pregnenolone because there isn't one. So you're not going to cause it to spill up back into the bloodstream. So the cholesterol levels won't be affected. Cushinoid dogs, in fact, the other dogs tend not to have elevated cholesterol, but the cushinoid dogs' cholesterols actually go down even though the enzymes are being blocked. Yeah, that's good. All right, so it is available. Obviously, we used it for a long time via compounding pharmacies before it became available as the Vetoryl product from Decra. It is available now in 10, 30, 60, and 120s. The dose is interesting because the dose on the studies that were done in the U.S. and especially the studies that were done in Europe, the dose range was 2 to 50 milligrams per kilogram. So what we've been doing as we've used the drug more and more and more and more and more is our starting dose keeps going lower and lower and lower and lower and lower. And so right now we start most dogs at 2 mg per kg once a day. We're going to start them lower than what's probably on the package. And then we're going to raise the dose as we need to, and we'll show you how we raise the dose and how we go from once a day to twice a day dosing. We still start once a day. I'll show you some data on BID dosing. We still start once a day because over 80% of the patients respond to once daily dosing, and I think it's just easier for an owner. But if they need it twice a day, we can certainly do it twice a day. We can talk briefly about compounded preparations. A nice study out of Texas A&M. Same thing to what they sort of did with Cortrosyn and compounded ACTH. They had 5 different compounding pharmacies make up a 30 milligram capsule of Trilostane. Then they took 30 milligram Vetoryl capsules, sent all that stuff to a lab. They did GC mass spec, measured how much Trilostane was actually in there. It was all over the map. Okay, so the biggest problem, I think, with compounding these products is that if you're having a dog who's on a compounded form of Vetoryl and you're having inconsistent control of symptoms and really weird ACTH stim tests, like 1 month he's controlled and 1 month he's not, and he's on the same dose, probably what's happening is that the amount of Trilostane he's getting in the compounded product is varying. And this drug is something that has a half-life of 8 hours. So it wouldn't be that unusual to expect that you're going to get weird control fairly quickly. So ideally, if you can get them to fit one of the manufactured capsule sizes, I would do that. If you can't and they absolutely need a compounded strength or they need it in a liquid because they can't take a capsule, I think I would do that. But I would certainly try and use the real stuff if possible. We give it with food because it's insanely well absorbed with food and not well absorbed on an empty stomach. So in order to get blood levels and to get adrenal suppression, really should give it with food. And again, we dose it in the morning because that's when we're going to do the monitoring because we're going to monitor them 4 to 6 hours post-pill. So if you look at a dog who gets a single oral dose of Trilostane, same thing with ketoconazole, within 30 minutes your cortisol levels start to drop. They're going to stay low for about up to 8 hours, and then they're going to start to creep back up again. So that by 24 hours, the cortisol levels are going to be back up to baseline. Now, despite the fact that the cortisol levels are going back up to baseline with once-a-day dosing, what we think is happening is that we're getting good enough control, good enough suppression of cortisol that the symptoms are going away. And again, when we're using Lysodrine or Trilostane, we're not treating the underlying cause. We're not treating the pituitary tumor or the adrenal tumor. Your goal is to get rid of symptoms. And so if you're getting rid of symptoms with once-a-day dosing, then life is great. If we're not getting control with once-a-day dosing, then either we need to raise that dose or we need to go to twice a day. And the reason that we stim the dogs 4 to 6 hours post is that that's maximal suppression. So all of the studies that were done in the UK and done in the US to look at efficacy were all based on stimming a dog 4 to 6 hours post-pill. With Lysodrine, it doesn't matter. It doesn't matter what time of day, it doesn't matter when relative to the pill that you do a stim test, because that drug's a cumulative effect on the adrenal cortex.
Would you raise it even if your ACTH is okay?
Here we go. People reading slides ahead of time. Super annoying. Okay, we're going to talk about that. She told you. This front row is all a disaster. She's going to be pregnant, and she's going to whelp here in a minute. And these two, instigators. Okay, so yes, we're going to ask that question. So once you put a dog on Lysodrine, what we usually tell you to do, bring him back in 10 days and stim him. If the stim test looks good, and we'll tell you what good looks like in a minute, bring him back in a month. If that looks good, then bring him back in 3 months. And then every 3 to 4 months, you should stim him. And every time you stim him, you should, in theory, check electrolytes. Because you're wanting to look at not only glucocorticoid, but mineralocorticoid function. Now, does that mean we make every single person do this? No. We have clients who've been on the drug for a long time. Their dogs are insanely stable. They're cognitively intact individuals. They know when their dog's not feeling well. So what I will tell people who've been on the drug for more than 6 or 8 months is, look, if you want to push it out to 4 months or 5 months, I'm okay with that, as long as you bring him in at any time he gets sick. Because if he gets sick, we want to know, is it from the Trilostane? Is it from his Cushing's? Is it because he's got a concurrent illness? And the only way we can answer that question is we need to see your dog then. So I'm okay with pushing out the interval in people who are fairly normal. In people who aren't normal, we send them to another hospital. Now, how quickly does it work? If we were to superimpose a slide of remission of symptoms with Lysodrine, it would be virtually identical. Works very quickly, especially with PUPD, panting. Those things go away fast. Hair coat changes, depending on the breed, can take longer. And the thing we have to warn some owners about is that some dogs, when they grow their hair back in, it comes in a different color. And they don't like that. So you need to warn them that, look, it may come back in darker or lighter than where it was before, and they've got a dog with little patches all over the place. That's not unique to Trilostane. That just happens because of the sex hormone receptors. How many people have a DVR? Really? What the hell goes on in this part of the world? I have a DVR. Whatever. TiVo? They make that shit still? No. Your pregnancy is affecting you. Their TiVo, it's gone. No, there's no TiVo anymore. I have a DVR that records no programs. My DVR records commercials, and it immediately only records pharmaceutical commercials because that is the best television on the face of the planet. And your typical pharmaceutical commercial is like this. There's 2 naked people in the middle of the wilderness sitting in tubs with no water. Nothing about this is slightly inviting to me because I sit there and go, what in the hell? How did they get here? How did they get the tubs here? Why is there no water? How are they getting back home? And in the background, you hear this lovely thing about all the magical, mystical things that are going to happen when that dude takes that pill. And you're going, yeah, that sounds pretty good. And then you hear in the background, you may go blind, your arm may fall off, and you may die. And at the end of it, you go, yeah, I don't care. I want that pill. The reason I say this is because when you send Trilostane tablets home with an owner, do not send them home with the package insert. The package insert is on the face of the planet because of the people in Rockville. It's not on the face of the planet as an information piece because they will read the package insert and they will go absolutely insane. Because what it says on the insert is rare reports of adrenal necrosis that may result in death. Now, adrenal necrosis can happen in dogs on Trilostane for reasons that we don't understand. And the 600 dogs that we've treated, we've had 4 or 5 cases where we know for sure the dog developed acute adrenal necrosis, became full-blown Addisonian permanently. A couple of dogs with adrenal tumors bled because the tumor went necrotic and they bled from their necrosing adrenal tumor. Why does it happen? We don't know. What we think happens is that if you look at that cascade again, that pathway, one theory is that when you give a dog Trilostane, if you block all of the enzyme activity in that adrenal, the cells go apoptotic. They die, and it undergoes adrenal necrosis. It has to happen in well under 0.1% of dogs who take the medication, but it's not something that was anticipated. It wasn't something that we saw with ketoconazole or with metirapone. It was unique to Trilostane. So we'll have some veterinarians who say, I don't like to use Trilostane because I'm worried about adrenal necrosis. To which I say, okay, that's a reasonable thing. What drug do you use to treat Cushing's? And they say, well, I use Lysodrine to treat Cushing's. And then we have a conversation that goes somewhat like this. What percent of dogs on sledgeline develop adrenal necrosis? 0. What percent of dogs on Trilostane develop adrenal necrosis? Less than 0.1%. What percent of dogs on Lysodrine develop adrenal necrosis? Frickin' 100%. That's how it works. But you, in the back of your brain, you sort of expect it. You know that's how it works. You're worried about the side effects. You put the fear of God into the owner about when to come in for stim tests. So yes, it can happen, but it's exceedingly rare. The other thing that shows up on the package insert is sudden death. That's never good. Nobody likes sudden death on the package insert. But the reality is that, freaking dogs die. And you don't know why they died. And in the course of the study, they had some dogs in the treatment group that died unexplained. They didn't have a necropsy done. And so they have to write on the package insert sudden death. We did a study a few years ago for a drug company where we had 3,000 dogs in the study, 1,500 on placebo, 1,500 on medication, followed the dogs for 2 years, wrote the package insert for the product, sent it off to Rockville, Maryland, got an interesting phone call from the folks at Rockville, said, check your email. I said, oh, that's never good. Clicked on the email, letter from the FDA, here's your package insert. Down at the bottom under side effects, may cause drowning. Now, I thought that was unique because the medication we were looking at had nothing to do with swimming in dogs. It was not involved remotely with water or water activities. And I called them up and I said, okay, what the hell? And they said, okay, here's the deal. You had 6 dogs in the placebo group that drowned during the course of their 2 years of being alive on the planet. And you had 9 dogs in the treatment group that drowned. Therefore, your drug increases the risk of drowning. That really was not my response, the laughter. And I said, okay, let me explain drowning to you in this scenario. The dogs drowned because the owners left the gate open to their pool. And the dogs fell into the water. They can't swim. They sink to the bottom. Water goes into their lungs. They die. They float to the top. The 4-year-old finds the kid in the thing. It's disturbing. But it's got nothing to do with the drug. And they said, we understand that. May cause drowning. So we got on a plane and flew from Los Angeles to Rockville, Maryland, and spent an entire day explaining the pathogenesis of drowning in the dog and gates being open, took pictures of yards where dogs had drowned. It was a whole CSI thing going on. And they said, thanks for coming, may cause drowning. So you have to not give them package inserts. It's just not good. If you have dogs that are on Lysodrine now, and you're thinking, well, maybe we should switch them to Trilostane, what I usually tell you is, well, if they're doing well, don't do it. If he's doing well, clinically well controlled, no side effects, probably no benefit for the dog, go ahead and just leave him alone. If you say, I'm not getting good control of his symptoms, or as I raise the dose of the Lysodrine to get better control of his symptoms, he's getting sick, he's developing Lysodrine-induced side effects, and you want to switch him, what you want to do is take him off Lysodrine for at least a month. And the reason you need him off is that if you give him Trilostane too soon on top of the Lysodrine, you will make him Addisonian. So we want him off Lysodrine for at least a month, stim him, and if their post-ACTH cortisol is greater than 14, go ahead and start Trilostane like you were going to start it, like he was a newly diagnosed dog. Now, how efficacious is it? So in the U.S., there was a study done, 107 dogs, your basic age range, your basic body weights. 224 dogs were screened to get to that 107 dogs. 95 with pituitary, 5 with adrenal tumors. 1 dog that was felt to have both, it didn't. I'm sure that dog had an incidentaloma, it just never got worked up. And then 6 dogs, they couldn't tell. They ran a bunch of tests, couldn't tell which it was. The owner declined additional tests, so they just were enrolled into the study. Now, efficacy was 77%. 80% in the Lysodrine retrospective, 77% in the prospective Trilostane. And success was defined as clinical improvement, as well as a post-ACTH cortisol that was less than 9.1. Now, that's much higher than the post-ACTH cortisols we look at when a dog's on OPDDD. And that probably has to do with the fact the different mechanism of action. We're using an enzyme blocker versus an adrenolitics. We're using a drug that we're only giving once a day versus when we were using ketoconazole and we were giving it twice a day. Now, we already said that. What do you want to do if you have a dog who comes back in and he's been on once-a-day dosing and he's having persistent clinical signs? The PUPD is still there. What we do is that if his post-ACTH cortisol is greater than 9.1 at that 4 to 6 hour post, then we're just going to leave him on SID dosing and we're going to raise the SID dose by 25%. So you just raise the dose, send him home, have him come back in another 10 days, and see, A, are the symptoms improving, and B, do we now start to see suppression? And if you do, then he can just continue to be maintained on that once-a-day dose, whatever that dose is. However, you may have to go to twice-a-day dosing if you have a dog with persistent clinical signs. You do the 4 to 6 hour post-ACTH, and it's actually okay. It's less than 9. But the owner's still complaining of PUPD. You don't think the dog looks any better. What's probably happening is that if you were to stim that dog 24 hours post-pill, it would be really high. And so what we do in that scenario is we take whatever milligram dose of Trilostane we were giving once a day. Now we divide it in half and give it twice. So if he was taking 30 milligrams once a day, he's now going to take 15 milligrams twice a day. The reason being is that what happens is that when you start to double the dose, is that you give that evening dose that prevents them from going all the way back up. Then they get the morning dose, then they get another evening dose, and what you get is more of a cumulative effect. And so you're probably going to see that on the BID dosing, that their daily cumulative dose of Trilostane is not going to go up, and if anything, it's going to come down because of dose splitting. And there's been several papers looking at BID dosing from the beginning, just taking every dog, putting them on twice-a-day dosing. And in one study, the average dose was 0.2 to 2.5. That was one really weird dog. That was like one outlier dog. That's very unusual. Most of the time, you're looking at between 2.5 and 3.5 mg per kg BID on a twice-a-day dosing regimen. Now, what about survival? I mean, if you're looking at, well, from an efficacy standpoint, they're probably equal. From a side effect standpoint, Trilostane is better in terms of percent side effects is more like 5% rather than 25 to 40%. There is no prospective study face-to-face Trilostane versus Lysodrine. So all we can look at is pooling data from retrospectives. You look at the two largest case series of Lysodrine, average survival 750 and 720 days, with Trilostane 930, 900, and 660 days. The thing, though, that's biased in these, besides the fact that they're retrospective, the average age of the dogs in the Trilostane papers are lower. So these tended to be younger dogs, so they're still alive at the time that the paper was published. So can't really say, and really wouldn't expect that either drug would be associated with better survival time than the other. We've got to show this picture. So this is Harvey, is a young man. This is a dude with a divine light shining on him. Never been able to figure out who that dude is. This is William Osler. So William Osler is the god of internal medicine, wrote basically the Bible of internal medicine. And he and Harvey were buddies. They were actually next-door neighbors when he was at Yale. And when Osler passed away, Osler's wife said to Cushing, look, can you write a biography? You know, he was your best friend. You know, you guys were colleagues forever. Could you write his biography? I want you to write it. And Harvey said, I'll knock that sucker off over the summer. Get that thing written. Took him 7 years to write the Life of William Osler. How many people have the first edition, The Life of William Osler? Seriously? Okay, great. When it came out, it didn't win like the Geek Book Award of the Year. It won the frickin' Pulitzer. The man is a really good writer, so it's an outstanding book. You should look at that. And then if you look up here at all those people sitting up in the rows, there's, 20 men, 25 men, and there's 4 women. That's the Yale Medical School class. Those women are not in the class. It's an all-male thing. But I know that first woman right there, that woman has acromegaly. I'm 100% sure. That's why she's in the picture. So how do we decide then what drug you want to use, well, or what treatment? You want to address the primary disorder if you can, the tumor in this case. You want to control symptoms. You want to get rid of treatment-related side effects. And, of course, owners are always going to be freaked out about cost. We're going to decide on the medication or the treatment based on the severity of the dog's illness. What other symptoms does he have? What other medications is he taking that may affect the drugs that we want to use? Remembering, too, that we probably won't get 100% control of every symptom in every dog. So we always have to ask the question, is it worth dose escalating or switching meds to get 100% control of something, or are we happy with kind of where we are? Harvey thought the whole thing was absurd because he said just take them out. That's what I would do. So what we do in our practice, it's a general practice and a referral practice, so we get all kinds of things in there. For people who have dogs with only mild symptoms or people with cost concerns, we start them on selegiline first. Everyone else goes on Trilostane, and the dogs that go on to Lysodrine are the dogs that fail Trilostane. And again, the failure rate for Trilostane in our hands is very low. The dogs that we've had that have failed Trilostane, one of the consistent features of those dogs was that they had calcinosis cutis. And so I think the dogs with calcinosis cutis probably would do better for sure on BID Trilostane than SID Trilostane, and probably would respond better to an adrenollytic, especially if they have a lot of calcinosis cutis, because that will keep cortisol levels flat for 24 hours. You're not going to have up and down in the cortisols. Now, what we're looking at really going forward is what are better options. The drugs we have now are attacking the adrenal when the problem is actually in the pituitary. We're looking at radiation therapy, whether traditional radiation or a gamma knife stereotactic. We'll talk about surgery. And because I'm a medicine person, our interest is in drugs. And this is actually a drawing of one of Harvey Cushing's first drawings on getting to the pituitary. He thought about this quite a bit, figured out fairly quickly that coming from the top of the head, very bad to get to the pituitary. Going in through the mouth was better, but going in through the nose was even better. And that's how you do the surgery now. When we go and watch the surgeries at Cedars, it's a transphenoidal approach going in through the nasal cavity. The whole surgery takes about an hour to an hour and a half. They're in the hospital for less than 2.5 days. It's pretty slick. The nice thing that they have, again, is that the cella points forward. And so when they go in from the nose and go into the cella, they can just scoop everything that's in the cella out because there shouldn't be anything there but pituitary. Our problem is we come in from the bottom and the pituitary points up, so we just can't go in and curette because there's that hypothalamus thing sitting up there. So medications that we're currently looking at, one are drugs that block PPAR gamma. And PPAR gamma is a receptor that's overexpressed in pituitary tumors of dogs and people, not present in normal pituitaries. It's a gene that's activated in lots of different scenarios, especially with diabetes and obesity. And in fact, one of the drugs that you can use to treat Cushing's is rosiglitazone or Avandia, which is an oral hypoglycemic agent. And it effectively blocks expression of that particular gene. And we've done some work showing that if you take pituitary tumors out of dogs and people, implant them under the skin of nude mice that can't reject them, the tumors grow, the mice become cushinoid. You give them rosiglitazone, the tumors go away, the cortisol levels drop. And so right now we're interested in doing some studies on dogs with pituitary macroadenomas, really big tumors where the owners don't want to do surgery or radiation. We have a trial where they can enroll, go on to rosiglitazone. We give them the drug, and we do follow-up MRIs for 3 months. So if you have a dog that is out here and has a big pituitary tumor, downside of that study is they get to spend time in wonderful Los Angeles because we really can't ship the drug to our friends at the FDA across state lines. Although we have a lot of people who can get drugs into this country very readily from lots of places. I'm always fascinated by this because I can't ship it from California to Maryland, but I can get all kinds of other stuff for recreational use virtually everywhere. A drug that works really well is 9-cis-retinoic acid. The retinoids as a class, there's a lot of interest in them as anti-cancer drugs because they are anti-proliferative, anti-angiogenesis drugs. These drugs have been shown to block certain genes that lead to the formation of pituitary tumor growth in cell culture. Very nice study done by a colleague of ours in Argentina, Victor Castillo, took a bunch of dogs with Cushing's and randomized them into 2 treatment groups. Half of the dogs got 9-cis-retinoic acid orally. Half of the dogs got ketoconazole. And they used ketoconazole because they don't have access to Trilostane or Lysodrine. They followed these dogs for 6 months, looked at remission of clinical signs, looked at UCCRs obtained at home by the owner, plasma MSH to look at pars intermedia tumors because that's a marker for that, ACTH levels, and then scanned them, looking at pituitary tumor size. What they found was that in the 9-cis-retinoic acid group, significant drops in UCCR, ACTH, and MSH, and more importantly, the tumor shrank in these dogs when they were taking the medication, compared to the ketoconazole group where there was no effect on tumor size, MSH, or ACTH. Not surprising because that drug works at the adrenal gland, so you did see a reduction in UCCR. More importantly, when you looked at the treatment groups, there were 22 dogs in the 9-cis-retinoic acid group. 5 came out of the study. 3 died, 2 related to Cushing's, both pancreatitis. 1 died of congestive heart failure. It's arguable what that had to do with anything. 2 owners said, yeah, I don't want to play anymore, and took their dog home. But when you looked at the survival of those 17 dogs, what they found was that they treated those dogs for 6 months, and then they took them off the drug and followed them for another year. And what they found was that even off drug, they no longer had biochemical or clinical evidence of Cushing's, and their tumors had not started to grow back yet. It was a very shocking thing. Versus our ketoconazole group, where 11 of the 20 dogs died during treatment. This is why we don't like ketoconazole. 10 out of the 11 died from Cushing's. 1 died because the owner said, yeah, I don't want to play.
What is this 9-cis-retinoic acid? Is it available? And are there major side
You know what? You're like super frickin' annoying. Go away. So I called Victor, my buddy, my friend, who I thought we were buddies and friends, and I said, yo, I want your drug. He just started laughing and laughing and laughing. He goes, I can't give you the drug. He said, I can't give you the drug because the FDA won't let me send it to you, and you can't import it in the country. And I said, listen, I have a way around that. Don't you worry about that. I have many people who I can send to Argentina will bring back anything that I need them to. So you just put something in a box, and I'll bring it back across the border. And he said, yeah, well, okay, that's fine, but you have another problem. And I said, okay, what's the problem? He goes, it's a little expensive. And I said, okay, what's a little expensive? He said, $2,500. And I said, $2,500 to treat a dog for 6 months, and I'm curing him of his disease. I can sell that stuff like nothing. I want the drug. And he said, oh, no, son, $2,500 a day. Yeah, that stopped us pretty much in our tracks. So that drug is never going to be available. So what we suspect is going to happen is that people are looking at other retinoid derivatives that aren't under patent protection, which is what this company that gave Victor the drug is using it as a chemo drug for humans, wants to get it through approval, isn't going to let veterinarians have access to it, so it's dead. But the theory of 9-cis-retinoic acid is alive and well. Now, we talked about the pars intermedia tumors, which are the tumors that are mediated by loss of dopamine. These dogs have high alpha MSH because that's metabolized there. They don't suppress in the lower the high. Hard to cure surgically because you have to get up near the hypothalamus to get all of those cells. But they are crazy good responders to dopaminergic drugs. So again, Dr. Castillo took a bunch of dogs with Cushing's. Half got cabergoline, which is a direct dopaminergic agonist. And again, 23 unfortunate dogs got ketoconazole. What they found in the cabergoline group was that 24 of the 40 responded to cabergoline treatment in the first month. Then 7 of those went on to fail. So they responded initially, then the signs of the Cushing's progressed. Overall response was 43%. This is in all dogs with Cushing's. However, what they found was that when they identified the dogs that had pars intermedia tumors, all 100% of the pars intermedia tumors responded forever. So as long as they took the cabergoline, their clinical signs were gone, their hormone data showed that they were normal, and their pituitary sizes went back to normal. And these were dogs that he followed for up to 4 years. Cabergoline is available. You can buy cabergoline. It's used to treat people with acromegaly and prolactin-secreting tumors. It's dosed 3 times a week rather than every day. And if you email me, I can send you some information on cabergoline. It's not cheap. 20-kilogram dog, to treat him for a month, is probably going to cost him $8 to $10 a day to use cabergoline. But the nice thing about it is you're not going to have to do electrolytes, ACTH stims, that sort of thing. The only thing you have to do is monitor his clinical signs and use CCR. Because, again, they're not going to go addisonian or glucocorticoid insufficient. This is just some examples pre and post, pre-cabergoline, post-cabergoline with tumor shrinkage. The bottom one shows a dog with a pars intermedia tumor where you get normal contrast enhancement after the tumor goes away. What we're looking at now in dogs are two drugs. This drug was approved 2 weeks ago to treat Cushing's in humans. This is mifepristone, also known as RU486, which was the abortion pill. This is a drug that blocks the glucocorticoid receptor, but also blocks the progesterone receptor. So in blocking the progesterone receptor, that's what makes it an abortifacient. Blocking the glucocorticoid receptor is what helps control Cushing's. It's licensed for use now in the U.S. to treat cushinoid patients who are diabetic. So a diabetic cushinoid patient can go on mifepristone to get control of the diabetes before they get surgical or radiation treatment to get rid of their tumor. It's going to be very difficult. It's going to be fairly expensive to try and use it in a dog. And the requirements over who can get access to mifepristone are pretty regulated because of the fact that it is a human abortifacient. We've got good dog data on safety because it's approved for use in France, where virtually every drug is approved for use. And they use it in France as an abortifacient in dogs, so we kind of know what the dose is. And then the last drug that we're looking at is SOM230, or pasireotide. This is a long-acting somatostatin analog. Somatostatin is a naturally occurring hormone that decreases the release of other anterior pituitary hormones. So there's been some studies, and we're continuing these, where the dogs get it twice a day as an injection. So it's like insulin. They have to take it twice daily forever in order to control the symptoms. And what we see in dogs who take it is we get very marked drop in urine cortisol to creatinine ratios, whether they're taking the drug every day or taking the drug on an every other day basis. We see reductions as well in ACTH levels, if I can get that slide to come back up, and decreases in tumor size as well. Okay, so the tumors get smaller, their ACTH levels come down in response to the SOM230. And so we are actively enrolling dogs into that study. Again, if they have a pituitary macroadenoma and they have Cushing's and they want to visit Los Angeles, they get the drug and the MRIs and all that follow-up for free. And then briefly, we'll just talk about surgery, because that's the other thing that we're doing now is surgery for dogs with big tumors. The reason that we wanted to look at surgery was because if you look at disease-free interval and mortality in dogs treated medically, and we want to compare that to surgical treatment. So if you look at the largest amount of dog data that we have, which is with Lysodrine, if you look at survival at 1, 2, and 3 years, it varies from 30 to 60%. And if you look at disease-free interval, when you get out to 3 years, it's down to 44%. Versus looking at surgical treatment and a large population of dogs, this was in 160 dogs, 3-year survivals at 72%, disease-free intervals at 66%. Makes sense. It's a treatment of choice in humans. You take out the tumor, 85% chance that you're curing them of their disease. The problem has been finding people to do pituitary surgery. And so the way that we accomplished this was we were working with the folks in the Netherlands and what they were doing. And then I convinced one of our surgeons, who happens to be my wife, to say, that whole TPLO thing, that's really boring. You should go TPLO pituitary. They're very similar. And so she spent 2 years training with the guy standing behind her there. That's Adam Mamalak. He's a human pituitary surgeon. And pituitary surgery is a very weird thing in the human world. Basically, in the United States, there's like 4 people who should be touching your pituitary. Should you have the need for someone to touch your pituitary, please let me know. And depending on where you live, we'll send you to one of the 4. Adam's one of the 4. He's also one of the nicest human beings on the face of the planet, which always bothered me because he was a surgeon, and I kept asking him if there was something wrong. He was just super polite and always very friendly. So what we do is we do a transphenoidal approach through the mouth, but as opposed to what was being done in the Netherlands, we do it all on a monitor. So we do it with an endoscope. There's a rigid endoscope that goes into the oral cavity, projects the images up on a high-definition monitor. So instead of looking through a small little hole, we're actually looking at a much bigger hole. We can drill about a 4 to 5 millimeter hole in the basisphenoid bone and extract 1.5 to 2 centimeter tumors through that small opening.
When you take the tumors out, do they become then axonian?
Oh, that's just a phenomenally good question. I will show you. And the answer will be no. No. So what we're trying to do with the I'll show you some examples. So this is one of the first dogs we did. Lucy was a German Shepherd. That big white thing there in the middle, that's not supposed to be there. That was a 2.5 centimeter mass in the pituitary. She was diagnosed with PDH. She underwent a transphenoidal hypophysectomy. At 3 months, at 1 year, and 2 years, she was tumor-free, didn't have Cushing's anymore. What we do with these, there's 2 ways to approach these tumors. One is to do a complete hypophysectomy. So you go in, take everything. And when you do that, they have to be on glucocorticoid and thyroid hormone replacement therapy for life. So they have to take those meds. They have to take antidiuretic hormone for 3 to 5 days because you've taken out the pituitary. But antidiuretic hormone is only stored in the pituitary. It's actually made in the hypothalamus. So eventually the hypothalamus takes over the role and starts to secrete ADH. What we're trying to get to is a point where we do selective adenectomy. We're just taking the tumor out, leaving the normal tumor behind. The disadvantage of that is that then if there's the risk of leaving tumor behind. And so depending on how big the tumor is, we usually just go in and go for a complete hypophysectomy. If the tumor's smaller and the surgeons are confident that they can distinguish normal from abnormal, then we'll do just an adenectomy, in which case they're not on replacement therapy afterwards. And we monitor them to make sure. So these are just this is Maggie Tarlow. This dog lived 3 years after hypophysectomy and died of hemangiosarcoma. So we've put together, this is a paper that's coming out in Vet Surgery, 26 dogs. These are dogs with really massive tumors, though. These are dogs with tumors that are 1.5 to 2 centimeters. We had 5 deaths in the first 26 dogs. All 5 deaths occurred within the first 4 months of doing the procedure. We haven't had a death in a year and a half. Hopefully we won't have any more deaths. Mainly related to how we changed up the operative approach to the tumors, especially the ones that were near the carotids. The nice thing is that when we're looking at remission, 100% of them went into remission with respect to the Cushing's, so they were cured biochemically. We've only had 1 dog relapse with Cushing's redeveloping. That was a year and a half post-op. And when we re-scanned him, he had regrowth of tumor. They declined a second surgery or radiation, so that dog's right now on Trilostane. And then lastly, what we're looking at are tyrosine kinases, both EGFR receptor kinases and what are called cyclin-dependent kinases. We have a group of zebrafish, which basically are minnows. But zebrafish, for whatever peculiar frickin' reason, get a lot of pituitary tumors. And so we can treat these zebrafish with cyclin-dependent kinases and cure them of their tumors. So we're hoping to start a study looking at that in dogs as well. So if you have dogs with big tumors, MRI confirmed tumor greater than 1 centimeter, clinical signs of Cushing's, let me know, because if they want to participate in something, either surgery or a clinical trial, we'd be happy to talk to them. And then lastly, Harvey actually did hypophysectomies in dogs back in 1909 and 1910. That's where he developed the transphenoidal approach, was to go in through the mouth of the dogs. Recovered him from surgery, and then, of course, they didn't really know what to do with them because they didn't know what the pituitary did. And the dogs developed profound PUPD. And then, of course, they all died subsequently because they weren't replaced with cortisol. What he then decided is that maybe what we should do is take the pituitaries out, and then I'm going to auto-transplant the pituitary back inside the dog's head. So he took the pituitaries out, he drilled a hole over here, stuck it back inside the brain. Yeah, it didn't work either. Not everything works. I mean, what the hell? I mean, the guy's pretty smart. But he started doing that over 100 years ago. All right. Does anybody have any questions over anything Cushing's? Yes.
If they failed the first dose of Trilostane, you said you increase the dose, what percentage are you talking about?
I'd probably go up by 25 to 50%. Yeah.
How high can you go if you're worried about too high?
The question was, how high can you go? There is no upper limit. I would think that if you're getting above 10 mg per kilogram, he's probably simply not absorbing the drug. And I would switch him to Lysodrine, yeah.
How do you monitor an atypical Cushing's patient when their ACTH dims and everything is perfectly normal and you've got them on Trilostane?
Right. So the question is, you have an atypical cushinoid dog who's got a sex steroid overproduction. How do you monitor them when they're on Trilostane? You stim them. Because what you're looking for is you want to make them go flatline, because if their cortisols are flat, their sex steroids have to be low. You don't have to repeat the steroid panels. You just have to measure cortisol. Because if that's down, you know you blocked everything above it. Okay? All right. Thank you.